So this person obviously was going to need 2 antihypertensive medications. And then he was also going to need something with a compelling indication and the ACE inhibitor. So I combined an ACE inhibitor and a calcium channel blocker. But even I didn't do it too well. I did the calcium channel blocker at 5, and then it was actually an ARB, 160 milligrams valsartan. And when it came, it had dropped to 150. That was after a week. So I have to step up. And this is like the proof that when you see a patient, this one, it was more than the 20 millimeters mercury above target. Target should be about 130 because it's a diabetic or less. So what the literature is telling us is very true. So I've shown you this slide already. Why are we not on target? Therapeutic inertia. Dr. Baabu mentioned it. And then the next one is that medication adherence, because if you combine pills, you are likely to achieve that. And the other thing is, if the patient's blood pressure is not well controlled, don't give him 3 months. You have to see him like monthly and then monitor him closely. And then also race and ethnicity. It is said that we, the Africans, we have very bad high blood pressures. So it means that we should take good care of ourselves. And then the other ones are systemic things that you put down to monitor patients. Okay, so summary of key observations. Even in the most economically endowed areas, BP is not optimally controlled. Okay, and then there's no doubt about the fact that if we control them well, there are benefits. And then single pill combination medication enhances adherence. Therefore, it's something that we should always think of. And then even people who are already on medications, we should sell the idea to them that we're going to combine it for them, especially if you know that none of them gives any side effect. First line, ACE inhibitor, calcium channel blocker, complementary function activity. Diuretics can be added to any of them to add to the third medication. And in resistant hypertension, think of spironolactone as a 4th agent. And if the person has a cardiac arrhythmia, he's coming with an atrial fibrillation, he walks a little, gets palpitation, then there's a compelling indication to introduce a beta blocker. So if optimizing other medications will not help, you may have to drop them a little and bring a beta blocker on board. So this my last slide. And then this picture just to tell us the cognitive load of waking up in the morning and seeing that you are going to swallow all these medications. And my grandfather would say that now I'm eating the medication, not food, because the tablets are so many. Thank you very much.
Thank you very much, Dr. Adadey, for your presentation. It was very insightful. Thank you very much, Dr. Baabu, for your presentation as well, giving us the epidemiology initially, and then we just gone to the pathophysiology and the pharmacology. And if you took note of what Dr. Adadey mentioned, that many a time when a diagnosis is made, it's about managing the condition and also reducing the risk of complications. And so that's one of the take-home messages. And so prevention is key. And so it is important for us to look at how we can help our patients with regards to prevention of the condition altogether, particularly with regards to its complication. And so our next presenter will be taking us to prevention of hypertension and its complications. But before I proceed, I would like to say that this CPD is a special collaboration between the West African College of Physicians, Faculty of Family Medicine, and the Ghanaian Society of Cardiology. It is also in line with the Health Commemorative Day, which is held to make sure that such particular conditions are well publicized among the general public and also to enhance the knowledge of practitioners. The next presenter, as I mentioned earlier, is a senior specialist, senior family physician, and fellow of the West African College of Physicians, and the acting head of facility at the Trust Hospital. She is also a training coordinator in family medicine and assistant lecturer at the Accra College of Medicine. With over 19 years of experience in clinical, academic, healthcare, and leadership roles, her interests include chronic disease management, patient-centered care, medical education, research, and health facility management. She has contributed to several peer-reviewed publications and continues to play an active role in postgraduate training and healthcare quality improvement in general. I've worked with her a number of times and I can vouch for her interest in patient-centered care. Without much ado, I'd like to welcome Dr. Dora Agblewogbe to take us through the prevention of hypertension and its complications. Please, if you're on the call, kindly know that you can put your questions in the chat box and we'll take all the questions together after this final presentation. Thank you very much. Dr. Dora Agblewogbe, please, you have.
All right. Thank you very much, and a very good afternoon to all of us. I'm grateful to be given the opportunity to share my thoughts and hopefully also incite conversation about how to prevent hypertension and its complications. So my name is Dora Agblewogbe, and I want to find out what you've had for lunch. Did it look anything like what you can see on my slide? Glass of chilled fizzy drink with some fries sprinkled with a lot of salt? Or did it look anything like what you see on my right in the saucer, a corn cob, and chopped vegetables? So I've mentioned my name and I have these objectives. I will skip the current epidemiology and burden. Just a few pointers that relate to control will be what I will discuss. And then I'll identify drivers of poor hypertension control and then would apply evidence-based strategies to prevent these complications, cardiovascular, renal, cerebrovascular, and then we'll look at self-management and population level prevention strategies. So here I will state that my bias will be more for primary prevention, secondary prevention, not too much of secondary prevention of complications. So I'm sure you come along. Okay, so since there was a classification and definition, I think I'll skip this, but just for us to know that secondary hypertension is an important cause of hypertension in our population. It always has to be screened for. And so since this has been determined already, I'll skip. But just for us to remember that optimal blood pressure is less than 120 and less than 80, both systolic and diastolic respectively. We also want to indicate that there are different ways of diagnosing hypertension. The gold standard will be ambulatory, the 24 ambulatory blood pressure monitoring. However, we know in our circumstances, we are not able to do that for everybody. We can use the home blood pressure monitoring to help us. And these are the targets. So I'll just want us to remember that low and middle income countries contribute significantly to the burden of hypertension. And approximately 320 million adults, just under 23%, have controlled blood pressures. So I want us to lean towards the right side of my slide, and you can see that in Black people, the prevalence of hypertension and the burden is higher. We have a 1.5-fold higher rate of non-fatal stroke, 2.8-fold higher rate of fatal strokes, 4 to 5-fold higher rate of hypertension-related mortality, and 4-fold higher risk of progression to end-stage renal disease. So in Black people, this is something we need to consider. I chanced on a few studies which gave us some information on the complications in Ghana. And I think what I'll just want us to remember is hypertension being the primary driver for heart failure when we look at 45% in Komfanochi Teaching Hospital, 21.3% of people with heart failure had hypertension. And then heart failure also contributes significantly to mortality. The prevalence of hypertension control is sadly very low. And so these studies, Okine et al. And Bosu et al., Bosu et al. Did a systematic review, realized that the control of hypertension is 6%. That is pretty low, but it was a systematic review. However, Okine et al. also did a study and found a prevalence of hypertension control to be less than 23.3%. That is equally low. In that study, it was found that females were likely to have better blood pressure control than males, and increased pill burden, dyslipidemia, and a longer duration of diagnosis were associated with reduced blood pressure control. Majority of the patients in that study indicated that they were forgetful. They indicated that there were side effects of their medication and the pill burden was high, and that's led to missing medications. So I'm sorry if this slide is faint, but it just tells you that in 2021, the top 10 causes of mortality, our top 10 in male and female in Ghana was stroke. And the fourth in male was ischemic heart disease. So I brought an iceberg here. And usually when you see an iceberg, you see just the surface of it. But below the iceberg is where the trouble lies. And this iceberg, which we are going to encounter, is called obesity. So in Ghana, in 2022, children and adolescents had 7%. The prevalence was 7% of obesity in children and adolescents. And in adults, we find that 12.9% have obesity. So there's a prediction that 1 in 5 women and 1 in 7 men will be living with obesity in 2030. And that's just about 4 years from now. So we need to do something about it. So I'll skip through the risk factors since that has been done already. Pathophysiology, we know that it's a complex mix of environment. Now immunological factors are being implicated. We also know about lifestyle, and we know, as Dr. Adadey and Dr. Baabu have given us. So I think I will just skip this slide so we can go to our cases. So I introduced to you a patient I saw on the 30th of December, 2025. He was admitted on the ward, and he was not known to previously have hypertension, but at the time he was referred, his blood pressure was 210 on 123 millimeters of mercury. Yes, his blood glucose was high as well, and he's currently living with a right hemiplegia and aphasia. So meet my second patient who suffered a hemorrhagic stroke. He's 44 years. He had hypertension, was non-adherent because he had erectile dysfunction. He's not been to work for 4 months, and he stopped taking his medication after the stroke diagnosis and was readmitted on the 8th of May because he stopped his medications. And the reason was worsening erectile dysfunction. So let's talk about prevention of hypertension. And when I was preparing for this slide, a cousin of mine who is a niece actually, asked me, why can you prevent hypertension? So I think by the end of this, we'll be able to tell. So remember this strata of hypertension prevention, this strata of prevention generally, primordial, primary, secondary, tertiary, and quaternary. For the primary prevention, we want to prevent the complications, we want to prevent or delay hypertension, and we want to start at the optimal blood pressure, if you remember my first few slides. For secondary prevention, we want to screen and identify high-risk individuals. When we are done with that, we want to confirm the diagnosis. We want to take a detailed history, look at the risk factors, determine whether they already have target organ damage, the heart, the brain, the kidneys, the eyes, blood glucose, etc. We also want to assess their cardiovascular risk status and also exclude secondary causes of hypertension. So let's look at this very interesting slide. And it tells us how early hypertension starts. So for pre-hypertension, studies have shown that we have increased cardiac output by age 10, as low as age 10. So between age 10 and 30, pre-hypertension has started. So going forward, another 10 years, we have early hypertension in persons aged 20 to 40 years. And this is driven by increased peripheral resistance. Then establish hypertension in ages 30 to 50. And sadly, by age 40, in many Blacks, the complications start to show. Please remember this slide because we will come back to it in our discussion. So primary prevention, and that is where my main concentration will be. We need to indicate to everyone, our clients, our patients, that lifestyle management is primary prevention and can prevent or delay the onset of hypertension. So how do we prevent hypertension from occurring? First, we need to find out who is at risk. Who do we screen? So this may be a bit small, but the ages here are, the top age is at least men who are at least 40 years or older, women who are at least 50 years or older. And please, I just want you to look at that because we are going to debunk this. When you go down, we have obesity, a family history of hypertension in a first-degree relative. We have Black ethnicity, and I want us to keep that in our minds because knowing the demographic in which we are, or the demographic which we are presenting, we would need to start our screening very early. Who do we also screen? Those with comorbidities, diabetes, chronic kidney disease, obstructive sleep apnea, dyslipidemia. And at every visit, we need to screen. And when we diagnose people with diabetes and these conditions, we also need to make sure that we're keeping an eye on their blood pressures, even if they don't have that before. And lifestyle risks, so those who are smoking, those who are inactive, those who are eating a lot of salty diets, which is practically almost all of us, we need to also screen. Those who are pregnant, and we realize that sometimes in pregnancy, when people have pregnancy-induced hypertension, we lose them to follow up only for them to come with complications. And then those who are on medications, there are times you are put on medications for a non-hypertensive or non-diabetic condition, and you end up having diabetes. And then obesity and cardiovascular complications or comorbidities in children. So I'll jump this. I just want you to take this quotable quote that we should take screening and education on hypertension to our religious places of worship and to the schools. What has data shown us? And if you see the evidence here, means A means done by several randomized controlled trials, well done studies, and it tells us that lifestyle management is the way to go. Weight reduction, use of green vegetables, grains, that's the DASH diet. And if you realize, if you add a DASH diet to sodium restriction, you are really a long way down in lowering your blood pressures. The rest of them, aerobic exercise, alcohol reduction, increased potassium intake in place of sodium, and stress management. So in our day-to-day activities, stress management is very important. So how much salt is recommended? I won't bore you with this. I know there's a lot of information about this. It's a teaspoon of salt. So what does it mean to us if we need to tell our patients you are only allowed a teaspoon of salt in a day? It may mean you may have to eat only one cooked meal or some other interventions. So what's the DASH diet? So the DASH diet is a dietary approaches to stopping hypertension. Was a study. It came out from a study that was done, and it recommends green vegetables, grains, etc. for prevention. So we look at meal sequencing. So you ask a Ghanaian, oh, stop eating this or don't eat that. Actually, we should stop that. And you can actually indicate to them, eat the fiber first, go to protein, and go to your carbs. By the time you get there, you'll be fine. Exercise. I've gone through the list already. Exercise 150 minutes per week of moderate intensity or 75 minutes per week of vigorous aerobic activity. And we know that we have to risk stratify our patients. We can't tell an 80-year-old woman to go and do this. So we have to structure it properly. And as I was saying, there were studies that indicated significant reduction of blood pressure, especially in obese and overweight patients, when the DASH diet was combined with weight loss and exercise. So let's jump to secondary prevention. And for here, as I mentioned, we want to screen and identify high-risk individuals. We don't want them together in the first place, but we want to at least catch them as early as possible so that we can prevent the complications. So when a patient comes in, we need to accurately measure the blood pressure, and there are guidelines to that, and take a thorough and focused medical history, do a physical examination where we are looking at the organs. We want to make sure that there is no end organ damage, and then tailor our laboratory investigations. Now we need to look at the global cardiovascular risk. So it is not enough for someone to have hypertension. Indeed, studies have shown that about 60% of people with hypertension have other conditions. So they will have diabetes, overweight, central obesity, dyslipidemias, and all that, which are also risk factors. They all act at the level of the endothelium, and they can cause cardiovascular disease. So we need to assess using our calculators. One of them is the WHO International Society of Hypertension risk calculator, and there are several of them. It's just to risk stratify and make sure that we know whether the person has a high 10-year risk of developing a complication, stroke, MI, etc. So what do? We have to assess and manage cardiovascular risk factors in patients with diabetes, and I think I've talked about that. In secondary prevention, lifestyle management is still foundational. So for dyslipidemia, we know that the primary target of lipid-lowering therapies is the statin. And once we are able to tell whether the person has high risk or not, we can start either moderate intensity statin or high intensity statin and up titrate depending on and add on depending on whether our targets are being met or not. I also need to mention, because we know that renal impairment is very high in patients with diabetes, with hypertension, and we have a very nice heat map here, which I shall leave with you. We need to assess for renal impairment. We need to assess with albuminuria checks, urine albumin creatinine ratio checks, as well as the GFR. And we need to prevent diabetes and treat. All right, so what are the target levels for important cardiovascular risk factors? We are looking at a hypertension of, if it's generally only hypertension, we are looking at 140 or 90 or less. But now new studies have come out to show that even pushing the targets down to even 120, 80 in most conditions, of course, looking at the age is important. I won't go through this because of time. What are the labs that are supposed to be done when we have someone with hypertension? Dr. Adadey has mentioned some of them, so I think I'll just skip this and go to the next slide. So he's also talked about single pill combinations, which are better because you remember in the first study I mentioned, one of the first studies, pill combination, pill burden was one of the big reasons for non-adherence. So we start with a single pill, some single pill combination. Occasionally we can start with one medication, either a thiazide-like diuretic or a calcium channel blocker, and then quickly escalate to either a RAS blocker and calcium channel blocker. And then if the targets are not met in 3 months, we escalate to the triple therapy. So there are reasons why we would need to use beta blockers, and I think Dr. Adadey mentioned that. Now there are pharmacologic weight loss medications, which if indicated for patients with diabetes, patients with obesity, with hypertension, would also improve their control and management. This slide is very tiny, but it's just a flow chart to indicate how to titrate the antihypertensive medications. And same here, I'll leave the slides. So for us, we also want to look at organ protection. So we are looking at if the person has left ventricular failure, heart failure with preserved ejection fraction, MI, the ACE inhibitors or ARBs and calcium channel blockers and SGLT2 inhibitors are preferred. If you have to prevent stroke, small vessel ischemia, any regimen that will give you less than 130/80. And in the spring trial, we've been told that less than 120/80 gives a lower risk for dementia and other risk factors, cardiovascular risk factors, cardiovascular complications. So I wanted to do this, but unfortunately, I'm running out of time. I want us to remember that we need to manage blood pressure to go. It is not enough to see the patient and give medications, but we have to ask whether they are being treated to target. And these are the targets. So let's go back to these individuals. And remember that adequate blood pressure control plus control of other cardiovascular risk factors is equal to organ protection. And for them, they have bypassed that, and we are now managing the complications. So there was a study done by Sasu et al. And I think one of the big things in that study for me, it was done in Nigeria and Ghana. One of the big things was that even when blood pressure was controlled, so once you get blood pressure, it's like you are at risk of the complications. Even when blood pressure control, stroke risk persisted. So you are not out of the woods once you get hypertension. So look at self-management. Hypertension management that happens at the clinic is just education, but the patient is the one who manages himself or herself. So we need to look at how they are monitoring their other parameters. And there's this interesting, you can click on it. There's this interesting thing that has been brought by the National Health Insurance Agency, and there are vital booths where patients can actually check their hypertension, their blood pressures, blood glucose, lipids, and relay the information by telemedicine. And this gives you an indication of where the booths are located, and I've tried it. Patient-centered care. We cannot do anything in preventing hypertension, either its onset or complications, without patient-centered care. And we need to empower the patient to know that self-management is the key. We need to throw them into a pool of people who can manage them in a multidisciplinary way. The dietitian, the psychotherapist, the psychiatrist. Remember, my patient had erectile dysfunction and would not take his medications. We need to give them a chronic care team that supports their management. We also have to look at motivational interviewing. It's not enough to say you have hypertension, these are the medications, but we have to assist our clients or patients to manage themselves. And we can do that by motivational interviewing, looking at their cycle of change, and then use of telehealth so that those who cannot come in all the time and it's safe, they can use telemedicine. So I'll skip this. What are the big interventions? Big interventions. One, we shouldn't just decide to clear patients from clear. When you say clear, I hope we all understand. We need to get them into a system which is prepared for them with resources. We have to also prepare our teams, not the doctor says, go and eat this number of this recommended carbohydrates, and then the nurse says this, and then the dietitian says this, which all have one message. And usually the chronic care model by Wagner et al., which was used very well by a boss of mine, helps to manage patients in a comprehensive manner. So individual level, we screen. Facility level, use the chronic care model, coordinated care, referrals, and use of technology. How about community level? Exercise programs can be put in place. Look at primordial prevention, where they will put some bans on foods that are salty, increase access to vegetables and fruits, and then education, very crucial. So if I have a minute, I'll tell you, one of the vacation Bible school classes, one of the ENT surgeons talked to the children about the risk of aspirating when, a nut or a seed. And forever and ever, my 5-year-old daughter would always remind me about it. They are sponges. We need to take our prevention there. We look at the social marketing model. I've talked about this. We need work-based exercise programs, hospital-based exercise programs. We need to coordinate programs between hospital health facilities. And I dare say the traditional healers. Why do people prefer the traditional healers? They feel they can give them a cure while we are always hampering on control. What about the barriers? So I found a few studies which were quite interesting, that our health literacy is actually quite low. So you give a patient information and they do not understand. They are not able to read labels. They are not able to access information for themselves. We need to get that if we are going to have our hypertension controlled and we're going to prevent hypertension. How about the personal barriers? So we know this already, motivation and time. What does it mean to look beautiful? You have to be round, your cheeks have to be chubby, and you have to have a round belly. And then costs. What are the cost implications? Very high. There's also the fear of side effects, especially erectile dysfunction in men. So we look at other barriers, funding, resources, health infrastructure disparities, and herbal medication usage. So my last few slides, this is just about 2 more. I decided to say, what title should we give? We have people consuming energy drinks to survive because man more live. So what is it contributing to the prevalence of hypertension? And man more live is vernacular, please. So consuming sugary drinks, that is also a big problem, especially in our children, who, for being good, we pump them with good food, quote unquote. Now, the other issues are combined oral contraceptives and hypertension disorders in pregnancy, childhood obesity, and secondary hypertension. So what do? We want to reduce the screening age, and then can we also have people looking at our own specific cardiovascular risk factors? And did you know that babies are being bleached? So chain of prevention, I drew a chain of prevention, and I shall put up during the question and answer time. Now let's look at this lady to end my presentation. She's 46 years. She came in to the clinic because a health screening had picked up high cholesterol, and it was at the history taking that we realized that her mother had suffered a stroke at age 25, and she had no known previous medical condition. So guess what? We had to put all our preventive screening, labs, etc., monitoring, self-management into play. So she is going to be a little, hopefully, more protected than my earlier patients. But for the next patients, for the next MA, for the next WA, for the next JKB, how do we prevent hypertension? And then how do we couch the message in such a way that the adolescent who is obese, the hustler who sells coconuts, and my beautiful old lady in the village can understand and appreciate prevention of hypertension and its complications. So I thank you very much. Milo Brara is Siwu, and Siwu is from the Lolobi from the Volta region, from the OT region now. And these will be my references, and I'll end here. Thank you very much.
Thank you very much, Dr. Agblewogbe, for such an engaging and enlightening presentation. So we'll go straight into our question and answer session. So I believe all our panelists are ready to take them on. Whilst we put the questions together to ensure that we have a good flow, I'll just encourage us, as many questions that you would like to put in a chat box, kindly do so. We'll start from the chat box and then perhaps engage people by unmuting if that option is possible. But before we do that and getting our questions ready, Dr. Khalid will be in charge of that section. I'd like us to take a message from our sponsor. So Dr. Khalid is currently putting together the questions. You are still allowed to put in a question or two if you have any, or a contribution as well. Thank you.
I wouldn't be sure either. When it comes to quality, the choice isn't always so clear. Let me show you what German quality means to Denk Pharma. The quality of our tablets starts with the selection of the right active pharmaceutical ingredients, excipients, and special purified water. From the moment they arrive at our warehouse, each of them is inspected by an expert to ensure its integrity. The machines we use to manufacture our products are designed and built in Germany by companies like Fette, Koch, and Ullmann. These aren't just machines, they're the Mercedes of pharmaceutical production. Crafted with high precision, these machines guarantee the reproducible and reliable production of our pharmaceuticals, tablet by tablet. And thanks to the German dual education system, our machine operators are highly educated. They are trained to use and maintain these advanced machines the right way. Once the production is done, it's time for our final tablet check. By this time, over 100 tests have been done. Randomly selected samples return to our quality control lab. After the requirements have been met, Denk Pharma products receive a certificate of analysis. It is issued by a qualified person who personally guarantees for the quality of our tablets. Then, and only then, we distribute the final product to our customers. During the distribution, we work closely with logistics specialists. They are GDP certified and maintain optimal conditions for the storage and shipping of our products. Now, let me ask you again, if you know all this, which tablet would you take? Yeah. So when it matters most, choose Denk Pharma. For your health and the health of your loved ones. Denk Pharma. Quality for your health, made in Germany.
All right. Thank you very much. Dr. Khalid will be helping us in reading the questions from the Q&A and the chat box. I'm co-hosting with Dr. Marianne. So she will also be helping in the moderation as well. So we are very happy and grateful that you have stayed put with us to this time. Let's use the next 30 minutes or so to answer all questions, and then we can bring the program to a close. So Dr. Khalid, you can go through the Q&A, read the questions, and then let's get our speakers to address them for us.
Okay, thank you very much, Prof. Ejekun. So the first question is from an anonymous attendee who asks, to confirm diagnosis, what is the recommended time between the two BPs? So I think Dr. Adadey, please, are you still on call?
Okay, yes, I'm around.
Good. So maybe you could take this one.
Okay, so the patients, I mean, we have the protocols for checking blood pressure. So if I understand, is it when the patient is sitting in front of you?
So please, the question wasn't specific. It just asked whether, I mean, to confirm diagnosis, what is the recommended time between the two BPs?
The person meant, you said that the blood pressure should be repeated, not just one blood pressure check. So I have checked my blood pressure today. The BP is high. How early do I have to check it again to be sure that I confirm hypertension?
So it depends on how high the BP is and then how urgent we need to address that. So let's say the person comes and blood pressure is around 145, maybe 90. I mean, that's an elevated, it's a BP that is high. So what we need to do is that we could ask the patient to come back maybe in a week, but then we will also, between a week and maybe 4 weeks, we could ask the patient to come back, but we should institute some lifestyle modification and then ask the person to be following the diet, the exercise, and then he will come back. We create the same environment of the person resting calmly in a place. Our blood pressure measurements in our clinics are not conducive. We just call somebody, he sits down, and then we apply the cuff and then we check. So mostly what I do is that when they come, I apply the cuff, then I start engaging them in conversation. And I tell them, be very careful. When you're going to check the people's blood pressure, you see that they pull their chest forward, and that's exactly what I don't like. I just want you to be calm. So I tell them, there's a reason why I've attached this and I've engaged you in a conversation. After about 5 minutes, I check, then I get a rough idea what it is. If it's still elevated, I will not start medication right away because I've seen some people whose blood pressures are like 160, and as soon as they leave my office, it comes down to around 130. If you start medication, they start doing one thing with all the side effects, and they don't want to come to you again. So if it's around 140, I could let a person go do his lifestyle medication, see him in a month, and then recheck. That's the way I go about it. But I mean, anybody can also add an advice onto how it could be done.
So maybe if I can just add something small, and I think, I mean, we do the same thing. And out of now, the guidelines also recommend out-of-office blood pressure monitoring, because people come to the hospital and they may have white coat, hypertension and all those. And so once your blood pressure is elevated, out-of-office blood pressure monitoring is very important. So you ask them to check their blood pressures in the comfort of their homes, but you have to teach them how to check their blood pressure well, document it, repeated measurements, and then they bring it to you in the office, and then you can do the averages with them. If they cannot do it themselves, then ambulatory blood pressure monitoring, of course, but that is going to be a little bit more expensive than if they were able to do it themselves. So all these are measures that are available to us. Thank you.
Okay. And if I may add something small, I also recommend that they bring the blood pressure machine so that next time they are coming, they bring it so we could compare. with our calibrated machines. That's if ours are calibrated. And then we also have the chance to look at the cuff size and see if it is appropriate. Because if the cuff is very small, the BP readings will be very high. And then if the cuff is very big, the BP readings will be unusually very low. And it may give us a false idea.
Okay, thank you very much. So the next question is there truth in the point that thiazide diuretics are very effective in Africans, thus all medication plans should include these?
Okay. Should I take that one?
Yes, please. I think Dr. Adadey, you can take this one. I would indulge all other consultants on the call to kindly also help out with the questions and answers. So please, you are free to contribute to this Q&A session, all consultants on call and other presenters as well. And I want to point out that some of the questions have been answered in the Q&A box. So attendees can have a look at those as well. Thank you. So Dr. Adadey, please, you can go ahead.
Yeah, I think it's because it is believed that we have this salt and volume overload hypertension. So the diuretics, thiazide or thiazide diuretics are very effective in us. And for me, in my practice, I think there's some truth to that. That if I combine the calcium channel blocker, in those days I wasn't following any guidelines. So I combine the calcium channel blocker and then you are not on target. I just added a thiazide diuretic and it appears to work for us. I've not done any studies, but I think it's based on the fact that we have this excessive volume overload and then the salts also contributing towards our blood pressures. And there are patients that Caucasians have seen. And it's interesting that the dose of medication, maybe you give our people 10 milligrams of lisinopril, and yet they are still hypertensive. But some of these Caucasians, you give them even 5 milligrams, and if you're not very careful, they'll come back hypotensive. So our hypertension, I think the genetics is truly a bit different from other people.
Thank you, Dr. Adadey, if I may. Sorry.
Yeah.
Okay, so Dr. Appiah, I'll yield to you.
Go ahead. I just wanted to add that to what Dr. Adadey said, that indeed it's evidence-based now in the addition of hydrochlorothiazide or thiazide diuretic based on the Creole study which was done in Nigeria. And folks can, look that one up. A combined ACE inhibitors with diuretics, calcium channel blockers with diuretics, and there was a lot of benefit to the extent that the current guidelines, the International Hypertension Society guidelines, have all incorporated that. So maybe you started the evidence even before it was generated. So I think that's what I wanted to add. Thank you.
Thank you very much. Dr. Dora, please, were you going to say something?
No, that's fine. Thank you very much. I was going to make a question, but I think I'll yield.
Okay, sure. Thank you very much. So the next question from another anonymous attendee is that, okay, that's a comment. Great presentation. Thank you, bosses. Could you kindly share the slides afterwards? So I'm told the link to the recorded Zoom will be shared on the same platforms. The links for this presentation was shared. So kindly look out for that. For the presentation, would consult the presenters, and if they do agree, yes, we'll do that. Thank you. The next question is, I'm grateful for this session. Thank you. Please, my question is propranolol still used in the management of hypertension? And at what point can it be prescribed for a client? So I think any of the consultants, presenters could take this as well. Thank you.
Well, maybe I'll start. So propranolol is not used as an antihypertensive. It's not indicated for most of the conditions either. But if you need to use a beta blocker for other compelling indicators, like after a stroke, after MI, for heart failure, when you've stabilized the patient, usually propranolol is not used. So you would probably want to use a cardioselective beta blocker or a newer general beta blocker like carvedilol. But as far as I know, mostly in thyroid disorders, hyperthyroidism, there we occasionally use propranolol, but not for hypertension. I'll yield for the cardiologist on the call to answer that.
Thank you, Dora.
Yeah, Dora, you are right, and I agree with you perfectly. I mean, if you want effective antihypertensive doses of propranolol, you should be looking at dosing it 3 times a day, and that is going to be problematic. So now we prefer more the longer acting ones. And indeed, as you rightly said, beta blockers these days, if you look at the modern guidelines, are not even part of the first line medications as Dr. Adadey indicated. So it is when there is compelling indication to use a beta blocker. And in that case, unless the person probably has a thyroid disease, I don't think propranolol will be your go-to beta blocker to use. Thank you.
Thank you, Prof. Ejekum and Dr. Dora. So the next question is, why do some hypertensive later get low blood pressure and have to stop their antihypertensives?
Should I, Lambert, you are on, so you finish.
Well, I just wanted to say that it comes back to what Dr. Adadey said. When somebody comes with high blood pressure, you need to be sure that indeed that person is hypertensive. And in experience, you realize that somebody comes to you, the person is in pain. It is a wrong time to diagnose hypertension because pain in itself will increase that blood pressure. I've had so many patients come to me. You find out why they're particularly the young patients or maybe middle age, not hypertensive. They've been monitoring their blood pressure. All of a sudden, BP has gone up. It's important that you delve into the history to find out why. Quite often, they may have some source of pain. It could be a neck pain, it could be something somewhere. You are in a hurry, you start antihypertensives, they go home, that pain subsides, and that antihypertensive you gave once upon a time now becomes injurious and it drops that blood pressure, which apparently was just reactive to the pain. So I think it's important to establish that this patient is hypertensive, and that's what lends credence to what Dr. Adadey said. You need to see this patient on a number of occasions and establish indeed that the patient is hypertensive. So that's what I want to say. Dr. Adadey, over.
Thank you, Prof. And one thing that we also have to be careful about is that, it is thiazide diuretics and thiazide diuretics, they also cause some vasodilatation somehow. And you have to be very careful that you are not causing volume depletion with your medication, which by itself can drop the person's blood pressure. So if you find that a person is hypotensive, of course, you have to stop the medication and observe, but let's make sure that you are not over-diuresing them. The other thing that we should also look for is that there are patients, I've seen patients who are taking a combination of multivites. They were formerly controlled, and then they take all these medications, and suddenly they get out of control. Some were taking some painkillers. So a combination of the pain they were going through and the fact that these NSAIDs can also store water and affect their sodium water metabolism, they were also rendered uncontrolled. And when they were taken out, the blood pressures now responded to the medication. So it depends on what the person was taking before they came to see you. And these drug-drug interactions have to be well investigated. That's why we need comprehensive history and know what they are taking before we add on any medication. Because I have a 75-year-old man. He was taking ARB, calcium channel blocker, and a diuretic. And suddenly these days, his BPs are in the 80s, systolic 80s. And we have to stop everything. So there's something that personally I cannot explain, but there are moments where people dip and their blood pressures become low for about maybe 2-3 weeks, and then they become hypertensive again. So this one, we need the professors to throw more light on it as to what is happening to these patients.
Okay, thank you very much. And next question is, do you still deal with a 75-year-old BP as a monotherapy when recording is around 160/90? Do you still deal with a 75-year-old whose BP is 160/90 by treating with a monotherapy? That's a question.
Jameela, I think it'll be good to direct the question to someone, or is that?
Okay, so then okay, so Prof. Jokum, kindly take this.
All right, thank you very much. So if you look at the guidelines here again, I mean, if you are dealing with a patient 75 years, you need to look at other comorbidities that the person has and how tolerable they are going to be with the medications. General statement to begin with is, for majority of patients, we want to do a low dose dual combination therapy. But if this person has other comorbidities or is not able to, not very fit, then you may decide to start a monotherapy for this patient and quickly transition to dual therapy. What we will advise in this situation is you are not going to send that monotherapy to maximum dose before you introduce the second agent. Like if you decided to start, let's say, amlodipine 5 milligrams, your next step will be to add another agent to it rather than taking the amlodipine to 10 milligrams. But if the person is fit, 75, not major issues, you can start with your single pill dual combination therapy at low dose, and that also works well. For those beyond 80 years, that is where sometimes there's a bit of challenge. But look at all these patients in the context of their general fitness and well-being as well. Thank you.
Thank you very much. And the next is, most male clients have a challenge of sexual dysfunction while on the BP medication. Please, what is the way to manage these clients since it becomes a barrier to comply with the treatment? Thank you. And I must say there are 2 additional questions linked with antihypertensives, hypertension, and erectile dysfunction. Prof. Lambert, could you kindly help us with this one?
Sorry, Jameela.
Sorry. Yes, please.
I was trying to make a contribution to the last question.
The one on ED?
No, the one on the monotherapy. So
okay, please do.
What Prof. Ejekum has mentioned. I want us to remember that we need to look at whether the person is adhering. So the person is taking their medications, and then we can confirm with out-of-office blood pressure monitoring as well. Thank you.
Thank you. So, Prof. Lambert, please, if you are on, kindly help us with the question on sexual dysfunction and the antihypertensives. What's the way forward?
Right. I've just changed location, so in case you don't hear me properly, I'm on the move. But is there a question relating to ED associated with therapy or when you're hypertensive? Is that correct?
Yes, so it's talking about the challenge of sexual dysfunction while on BP medication.
Okay.
How do we manage these clients? Because the antihypertensives become a barrier. I mean, the ED becomes a barrier to they taking their antihypertensives?
Right. Thank you very much. So it's also important once again to establish if the ED wasn't there concurrently with the clinical diagnosis of hypertension. I say that to mean that hypertension being there will accelerate atherosclerosis, which we all know. The lumen of the pudendal vessels is about 25% that of the coronary artery. So if you're doing, particularly if the patient at the time of diagnosis has a coexisting ischemic heart disease, chances are that ED is already there on arrival. So we need to establish if ED was there prior to or concurrent with the diagnosis of hypertension. That said, there are notorious antihypertensives, which we all know that can do erectile dysfunction. We do not use them routinely in clinical care unless, of course, there are clear indications. At that time, it is weighing the risk of not treating the hypertension versus the risk of mortality or morbidity. The third point is that there are newer antihypertensives now, just as technology has evolved, so has the formulation of medications also evolved, so that side effect profile of these medications are way, way better. Indeed, there are even beta blockers, there are some antihypertensives that can improve your erectile dysfunction. So what I would say is that whoever is concerned about erectile dysfunction needs to have that frank conversation with a clinician who is seeing, and to be sure that either predated it or is concurrent. And if it's concurrent, there are medications that can be given to always ameliorate or mitigate that effect. So I think regardless, it can be properly managed. Thank you.
Thank you very much, Prof. Lambert. The next question, Dr. Dora, I think you mentioned this, so kindly answer this briefly. How are babies getting bleached?
Well, so general thinking locally is that the fairer, the better. And so very young toddlers are being bleached so that they look fair, they look chubby, and they look nice. I don't have studies, but I've seen a couple of toddlers who are being bleached, and I know a number of people who have seen that as well. So the concern for me is that this is also is going to be one of the contributors to the development of hypertension, diabetes in future because of the disruption of the hypothalamic pituitary axis going forward. So it's something that we need to look at.
Okay. And I've been signaled that we are running out of time. And since you are there, kindly just add this to it. It's also for you. It says Dr. Dora Agblewogbe on the Wagner chronic care model. Any adaptable lessons for us locally? So that's a question directly to you.
Okay.
So kindly answer that. Yeah, thank you.
Right. So what is our typical clinic like? A patient just pops in, we diagnose hypertension or comes in for a review. We don't really have a prepared team that, let's say, okay, if you have a hypertension clinic, then yes, likely you have a physician who is prepared to meet you. But otherwise, in primary care, the patients come in as and when. But if we create a system where the patient is expected, that's number one. So we are not just at the OPD waiting for the patient to come in, but we know that this is a chronic care clinic. We know these people are coming. We have their database. We are able to track them. That's number one. And then the team that manages them is also a proactive and prepared team. So we have different staff, so nurses, maybe educators, maybe for diabetes, hypertension, there may be even a pharmacist, there may be a psychologist, there may be a team that will manage the patient. And then you also have community collaboration so that I can see a patient and then tell you, go and do your exercise regimen at a community facility. There's also patient empowerment and resources that are made available. So either by print or media. So the person is actually empowered with a lot of knowledge and a team around the person, and it has worked. So we can talk behind the scenes. There's also self-management as well. And then there's incorporation of evidence-based data. So you can actually use electronic medical records which have access to evidence-based guidelines, etc., so that the person is managed holistically. Thank you.
Thank you very much. Unfortunately, our time is up, so we'll have to wrap up this insightful session. I'll call on our co-chair to give us her closing remarks, and that's in the person of Dr. Opoku Ajakwa. So, Doc, kindly unmute and then give us your closing remarks.
Thank you very much. Indeed, a very stimulating discussion we've just had. And good afternoon to all the distinguished participants of this CPD program on hypertension. Like it has been said, it's a collaboration between the West Africa College of Physicians to mark the commemorative Health Day celebration and the Ghanaian Society of Cardiology to mark May, the month of hypertension. It is indeed a great honor and privilege to have you all here. You have stayed and you have been really engaging. The West Africa College of Physicians remains a beacon of excellence in postgraduate medical training, research, and specialist training across West Africa. It was established with a clear commitment to advancing healthcare standards and continues to play a pivotal role in building capacity, strengthening health systems, and improving clinical outcomes of our people. We are reminded today that hypertension remains a leading risk factor for cardiovascular disease, stroke, and renal failure in our region, often presenting silently, yet leading to devastating consequences. Despite advances in diagnosis and management, there are still gaps in awareness, control, and long-term care. Today's program is therefore more than an educational exercise. It is a call to action. The program has afforded us the opportunity to deepen our understanding, update our clinical practices, share experiences, and strengthen our resolve to combat this silent killer. Through the robust discussions and expert presentations, there has been a lot of collaborative learning, and we have equipped ourselves with the knowledge and tools needed to improve detection, management, and prevention. As physicians and medical practitioners, we hold a unique position to influence the populace. Our patients trust us not only to treat their illnesses, but also to guide them towards healthier lives. Our communities depend on us to lead efforts to address public health challenges, and our profession demands that we continually learn, adapt, and excel. In closing, therefore, I reaffirm the West Africa College of Physicians' commitment to supporting professional growth and empowering everyone to deliver the highest standards of care always. Today, through all the knowledge shared, all the collaboration that will come out of this, and the dedication, we hope that we can make significant strides towards reducing the burden of hypertension and improving the well-being of our people. I thank you for the opportunity. Good afternoon.
Good afternoon, Dr. Marian, and thanks so much for your final words. So at this point, I'll call Prof. Ejekun to close, to also give his closing remarks. Prof. Ejekun, you have the floor.
Thank you. I mean, the closing remarks has really been given by Marian. Marian, thank you very much. We are grateful to all of you for joining us. It's been a very stimulating discussion from the Ghanaian Society side of things. We are grateful for giving us this opportunity to do this work. We thank Prof. Lati. We saw you here. I don't know whether you are still with us. We are very grateful when we see our mentors following us everywhere. And I think we have so many of you around. I can't mention all of you one by one. So we want to say very big thank you to all of you for supporting this. Our president, Dr. Collins Kokoro, thank you very much for the pushing from every angle and making it successful. I think the month has been very successful. And by this, we bring the whole month of activities in promoting hypertension to an end. We declare the May Measurement Month and Hypertension campaign for 2026 duly executed and ended. Thank you.
Thanks so much. And we are indeed grateful for a successful month of hypertension. I want to thank all our presenters for their excellent deliveries, and then all our participants as well who made this discussion very engaging and interactive. And of course, my co-host, thanks for doing this with me. And once again, thank you very much, and do have a good day. Bye.
Thank you. Blessed week to everybody.
Thank you very much.